Deep, thank you so much for the kind words, but I hope my screen is visible and I'm
Yes,
audible. Okay.
yes, absolutely.
I do have financial interest with Elisa, but none of it pertains to my talk today. Um, I do have to mention that some of these cases are not, they're very, very graphic in nature. So, viewer discretion. Uh, but okay, so here goes. When we see a Marfan's or when we see a subluxated or a congenital deformity like this, a lot of us do think, what do we do next? And we do wonder whether we should put the lens in the bag, or how do we go about it. But we've come out with a 10-year literature on actually doing glued intraocular lenses in these cases. But the way I do it is very, very interesting, and I think that's something that even if 1% somebody learns it, it could help, because we've got a lot of literature and published articles on this as well. So basically, I'm making my partial thickness flaps and making a sclerotomy about 1 millimeter behind the limbus in these in these cases, and using the same sclerotomy, I'm actually doing a lensectomy. But sometimes, when these subluxated lenses are too subluxed, they flop around a lot and they move around. So one tip and trick I'll tell is hold the bag with the left hand, and that really holds the whole lens. Even if you don't have any zonules in place, you'll actually be able to bring out this nuclear matter, all the cortical matter from inside. Then perform your anterior vitrectomy, use some Kenalog if you need to, and perform your complete anterior vitrectomy. After which, I do perform my glued intraocular lens. People, if they wish to do a Yamane, that's also fine, but intrascleral haptic has definitely proven to be much more stable in the long run in these very, very young patients. So what basically I'm doing is externalizing one haptic, then using a handshake technique, externalizing the second haptic. Some more often than not, you'll see that you can tighter these haptics in size and actually bring them to centration. I did use some meiotic over there to get this pupil down and right in size. Once I've done that, I've used my Gabor Chariot's tunnel to kind of tuck these haptics into place. And pretty much end of this case is here, and we've just some stromal hydration, put the glue under the flap, and close this wound completely. This is one of the cases of a complicated cataract in a young congenital patient. Here's another one, a different one, but let's have a look at how we manage this as well. So the basic construct here is, I don't know what's happening, honestly. This is just a white cataract right in the middle, and once you go ahead and remove this rexus, once you perform your rexus, you're able to then start seeing what kind of comes out of this. Is it a plaque? Is it a nucleus? Or is it a cortex? Is it fibrous capsule? I'm not sure what it is. So after I've done my irrigation aspiration, in this case is mostly after any of the soft nuclear matter comes out. Most of the cortex just comes out pretty easily with Simcoe cannula is what I'm using in this case, because I did not want to go ahead and push in irrigation at that pace and jeopardize my bag. But what I also found was this thick plaque of fibrous capsule slash fibrous nucleus of sorts, and it was stuck to the capsule. Fortunately for me, it didn't actually create a PC rent, but I was unable to bring this piece out with anything. I tried to dissect it, I tried to stab it, I tried to cut it, I tried to irrigation aspiration on it. It just wouldn't move. It was a thick plaque right in the middle. So I actually had to hold it with one hand and cut the piece into two halves, after which it could burp it out in some fashion, and the other one was basically removed with using microforceps. Once this is done, you check your irrigation, check your cortex all around again, and make sure that you have your rexus in place. Once you know that your rexus is intact and your bag integrity is all the way uh, ensured, then place your lens inside, and you can choose to do the YAG later on, but I like to do my uh, PCCC with using a vitrectomy cutter then and there on the table itself, so that I know that the patient will have some amount of vision as soon as recovery is there. Otherwise, 2-3 weeks at least before you can do the YAG. So that's one of the reasons why I like to do this on table then and there if I place the lens in the bag, especially being a young patient. Another patient which is very even more tricky and interesting is one of PHPV, that is persistent hypoplastic primary vitreous. And this is an animation which I'm showing, and I'll show you the real case after this. So basically, there's a fibrous stalk, fibrovascular stalk right in the middle, and this fibrovascular stalk really needs to be ligated before you can actually cut it. You can't cut it. You have to cauterize it before you ligate it, and that's basically what I'm trying to show here, which is what you have to do in these cases. So I'm just showing you a animation before I show you the actual procedure, what I did. So you can see that fibrovascular stalk right in the middle, the white one with the vessels flowing all around it. And here I've taken my diathermy and doing a cautery of it. So you can see that the blood has not yet stopped. So I really need to make sure that it's completely cauterized before I can take this plaque out. Once this is cut, I still have to cut away all the vitreous adhesions that are there around it. And now I have a central area of visibility, using which I'm doing my glued intraocular lens procedure. And it's kind of tricky because at these times you really want, the patient has come to you with the white reflex is what really is troubling the parent. And I know that the vision restoration is not in our hands in these cases, more often than not, because it all depends on how well this patient will recover from here on end. But once you see that stalk, don't try and meddle with it too much, because that can bleed and it can basically abort your case right then and there. So I try to remove as much of the blood as I could and hope for a regression to happen on that stalk itself. Uh, Post which I have placing my intraocular lens in using a glued intraocular lens, so that there is no more surgery required for this patient in the post after this, at least for the next 8-10 years, before which we have some opportunity of vision to grow back for this patient. Once I've done that, I'm again doing my Gibbons Chariot's tunnel and placing my haptics under that flap. My flap is now closed with glue and conjunctiva closed as well. Uh, this is pretty much the end of the case. Unfortunately, the patient was too young for me to take a clinical picture post-operatively and was not from town, so has did not come back post this. I did though follow up with that patient and has been doing pretty well. Not, I wouldn't say 6'6" for sure. This is another patient that looks similar, but is not so similar in its own sense. Uh, well, this actually happened very recently. It was an 8-month-old child, and if you see here is a fibrous membrane on the pupil, but more importantly, the anterior capsule did not look normal to me at all, because the minute I tried to puncture it just wouldn't go through. It was completely fibrosed, and I was only able to do it with a blade, with a 15-degree blade, and after which I had to literally cut it all the way around. I tried to, extend using a forceps, but it just wouldn't uh, go through in any format of its own way. The complete fibrosed capsule over here we have here. And how much ever you use a bimanual technique, you use a single handle technique, it didn't budge whatsoever. In fact, the zonules were getting weak. So what I tried to do now is make a new entry from below, from my subincisional area, and completely cut it all the way around. That was the only way I was getting past this thick anterior capsule. Again, using any maneuver did not help over here. So again, use my bimanual technique of using a micro scissor and removing this anterior capsule. Once this is done, I still don't know inside what's the scenario here. Okay, so I am taking out all the cortical matter from this case, but if you see here, the posterior capsule is completely thick fibrosed with a vascular membrane. But I fortunately did not find that fibrovascular stalk that was hitting the posterior capsule at its center. So I'm pretty sure that this was not a case of PHPV, but there was a fibrous bag over here, which needed to be cut with a vitrectomy cutter, and that is what exactly I went ahead and did, using a vitrectomy cutter. And as soon as I did that, I was able to see a beautiful red glow that gave me a little bit of satisfaction that this patient actually might end up seeing something. I did leave this patient for the time being in this fashion because the lens is in place, the uh, central visual axis is completely okay. And I just wanted to measure that there was about 4 millimeters in length, and it was a decent amount of opening that I had given. So uh, ho- hopefully that this patient would be able to see something at the end of this. uh, just in interest of time, I'm going to stop my presentation. I do know that there are other speakers as well, so thank you.